Thank you, Dr. Thomas. Good morning, everybody. Today, we're joined by Noelle Marie Javier, who is an associate professor at the Icahn School of Medicine at Mount Sinai, the Brookdale Department of Geriatrics and Palliative Medicine. She's primarily an inpatient provider towards patients with geriatric and palliative care needs. Apart from her clinical duties, she's had opportunities to conduct research, publish, and present at local, regional, national, and international conferences, such as the American Geriatric Society, the American Academy of Hospice and Palliative Medicine, and the International Congress in Palliative Care. Welcome, Dr. Javier, and thank you for joining us.
Thanks so much, Emily and David, for this invitation. I feel really honored and humbled to be able to present one of the major advocacies that I have, and also an area of strong interest as far as clinical work and research. I have entitled my session as The Gray in the Rainbow, the Geriatric and Palliative Care Approach for the LGBTQ population. I am Noelle Marie. You can just address me Noelle Marie, and my pronouns are she, her, hers. I do not have any financial disclosures. So there are two main objectives that I want to cover for this session. The first one is to describe key concepts, constructs, and guiding principles in the cultural understanding of the LGBTQ population. And then the second main objective is to provide practical, inclusive, and affirmative communication and clinical care strategies for this population. As a disclaimer, I would ask pardon in advance if this session, if the content of this session is simplistic. However, I think that we can always learn a thing or two, even just going back to the basics and learning more about LGBTQ plus medicine, particularly in the areas of geriatric, hospice, palliative, and end-of-life care. So I would like to start out with some evidence-based data in terms of epidemiology and some of the disparities in healthcare towards this population. The Gallup poll is a national survey that conducts surveys to include sexual orientation and gender identity collection. And they have been doing this since 2012, at least as far as including the SOGI information. And we can see that there has been an uptick in terms of the proportion of self-identified LGBTQ plus population from 3.5% in 2012 all the way to 4.5% in over 5 years. And then the most recent one was in 2020, and again, there's a larger proportion now and an increase by more than 1%. The reason why the 2018 and 19 years were not included was that, unfortunately, the previous administration decided to remove SOGI information from being collected in the demographics. And so this is the reason why we have lacking data from 2018 and 19. Moreover, in 2020, where we know that it's 5.6%, in about 15,000 respondents, more than half actually identified as bisexuals, and majority of them are women. So I'd like to take you back to the 2016-2017 data, which shows that the proportion of LGBT identified in the American population is about 4.5%. This was based out of a representative sample of about 1.6 million. And so therefore, it is estimated that about 10 to 11 million Americans identify as LGBT. What is more striking is that the diversity in which these self-identified Americans are, a lot of them, about 40% identify as non-white. As far as the geriatric population, about 2.7 million are age 50, and more than about 1 million are age 65 and above, which fits the criteria of geriatric or older adult population. Moreover, about 1.4 million identify as transgender. 1 in every 200 Americans actually identify as transgender. This data was lifted out of the UCLA School of Law Williams Institute. In order to fully grasp the impact of the life trajectories of our LGBTQ patients, I think that we also need to understand some of the different barriers, multiple barriers that really affected this population. And I'd like to put into focus a friend of mine, Jay Callow, who died of cancer a few years ago. He was a man who also identified as transgender, and he was such a great advocate for LGBTQ plus healthcare. And he really illuminated my mind in terms of the structural, interpersonal, and other forms of barriers that he received over time, from being a victim of bias and invisibility to having some structural barriers and being a victim of that, how to navigate the healthcare system, keeping in mind that there were difficulties in terms of access and availability of resources, financial constraints. He, a lot of the times, had to educate the providers about how he wanted to be cared for. And he was certainly mindful that there were gaps in policies as well as in research. So much so that he partnered with a lot of organizations to include NCCN, SAGE, and other well-known organizations within the healthcare system to really further the proper care for the LGBTQ population. So my hope in this presentation was also to memorialize and also to share with all of you what he had taught me as a person. In 2016, the National Institute on Minority Health and Health Disparities actually identified the LGBTQ plus population, also known as the sexual and gender minorities, or SGMs, as a health disparity population. We know from this picture that there are 29 states without LGBTQ non-discrimination protections, and you can see them in the grayed out states. The one in the red or maroon states are the ones that have LGBT inclusive protections and policies. And you can see that a lot of them are also very progressive states, such as in the Northeast, a few in the Midwest, and also on the West Coast. So there's a lot to do moving forward. So, the concern that we have with not just with all of those states, but really in general, because even within progressive states like New York State, there's still a lot of victimization that is ongoing, especially with rhetoric that can be really inflammatory towards the LGBTQ plus population. So this is a slide, and the next couple of slides will really highlight some evidence-based data supporting some of the disparities from the LGBTQ population experiencing harassment and refusal of care by staff, whether it's in the acute care hospital or long-term care settings. There's also fear of persecution and discrimination, whether it's perceived or actual, on the basis of sexual orientation and gender identity, or SOGI. Only a fourth felt that they could be open with staff about their SOGI information, and a lot of them are in the transgender and gender non-binary cohort. There's definitely gaps in knowledge and training for all clinicians and staff. And actually, one of the pioneering study by Lambda Legal way back in 2010, when Healthcare Isn't Caring study, showed that there is in fact a lack of clinical and cultural competency training for clinicians and other staff members. Moreover, transgender and gender non-binary people are openly made fun of with overt disapproval from staff and residents. Also, as illustrated in the previous slides, there have been numerous changes around LGBT inclusive questions on national surveys, such as the Older Americans Act and the National Census, and thereby perpetuating invisibility and inequitable allocation of resources. It's also not atypical that a lot of our LGBTQ plus population have increased financial instability and lower earnings across lifetime because of inequities in education and employment and outright discrimination in their employment spaces. There's also reliance on informal caregivers for social support. And we can actually describe the caregivers as two types. You have your vertical caregivers, which are typically your next of kin, nuclear family, biological relations. And then you have your informal caregivers, also called horizontal caregiving, which are individuals typically friends or other relatives that have been very supportive of their loved ones who are LGBT identified and have become what we call chosen families. And so what happens is that a lot of our LGBTQ population have experienced ostracization and isolation from their nuclear intrinsic core families and end up getting support from other members of their network. It is not uncommon as well that within the LGBTQ cohort, bisexual older adults have lower levels of social and community support. And in fact, it is there has been several data that has shown that the cohorts of bisexual and transgender, gender non-conforming are probably the most victimized individuals within the LGBTQ plus population and do not necessarily have easy access to social and community supports. The MetLife survey is another survey that was affirmed in 2015 by the US Transgender Survey that really looked at the impact of caregiving towards the transgender population when they become sick or when they become older. It is also apparent that the data since 2011, since the emergence of more data around LGBTQ plus population, that we have found greater risk of significant physical health outcomes and mental health outcomes, such as disability, psychological distress, obesity, and cardiovascular disease. And in part because of the fact that these individuals have been shunned and stigmatized to the point that they are now utilizing health maintenance and preventive screenings at a much lower rate, albeit more alarming rate compared to the cisgender heterosexual population. Now, looking at the transgender and gender non-binary adults in focus, though this is not specific to the geriatric and palliative care population, we can definitely see that across the board in all of these metrics, from HIV infection rate, incarceration, the rate of homelessness, alcohol and substance use, and suicide attempt, that the transgender population have a much higher rate of risk compared to the general population. What is even more jarring is the fact that 41% have attempted suicide in their lifetime. So with regards to the health disparities, it is not rocket science to then know that this will lead to significant adverse effects. Number one, there is a retreat back to the closet and detransitioning, leading to further invisibility of the LGBTQ plus population. And this could happen in long-term care spaces as well as in acute care institutions. Because of the disparities, there is going to be an ongoing unmet healthcare needs. And so therefore, this will have a cyclical effect on the physical and mental health outcomes, such as isolation, depression, anxiety, substance use disorder. There's definitely a lower rate and delayed utilization of preventive and health-related screenings because of fear that their open revelation or disclosure might cause outright discrimination. What also happens is that the healthcare systems at large are not set up to be able to really advocate for our LGBTQ population in terms of healthcare needs. Particularly in the olden days. Now we've definitely seen a turn and the healthcare systems are much more savvy and much more progressive in their advocacy. And we're thankful that we are in an institution that was rated by Diversity Inc. as the #1 health institution to advocate diversity, equity, and inclusion, including the vulnerable population, such as the LGBTQ population. And so therefore, in health systems in other states that do not have non-discrimination protections, one can only imagine that there could be complicity in terms of ignoring the needs and concerns of this population, thereby not necessarily committing to further training and investment of other resources to further and move the needle forward. Furthermore, there is also a lack of standardized policies protecting against discrimination and prejudice. So why are we having this discussion and why am I invited to give this talk? I think in part because there is a call to action that, this is an ongoing issue that we all need to be intentional and mindful and not just come from a place of, okay, I see that this is an issue, but really pushing ourselves beyond the boundaries to be able to do what is necessary so that we end invisibility for this population once and for all. In 2011, the previously called Institute of Medicine, now the National Academy of Medicine, really looked into the healthcare needs and concerns of the LGBTQ plus population. And what they found was there was staggering gaps in research as far as LGBTQ people's needs, concerns, and priorities. And I think that for all of us who are clinicians on this session, we do have an obligation to uphold human rights and respect the law, and that our role is not to decline to treat patients because of their identifiers, whether it's their race or color, religion, sexual orientation, or gender identity. And this is in fact encoded in the American Medical Association Code of Medical Ethics. What is, I think, more important to also identify is that you do not have to identify or belong to the LGBTQ population to do the work that we need to do. I think it's really stems down to the willingness and open-mindedness to be able to learn and to be able to apply and integrate what we've learned in day-to-day practice. So we have definitely seen an offshoot of a lot of different healthcare experts, as well as organizations from the American Geriatric Society, the American College of Physicians, the American Nursing Association, American Academy of Physician Assistants, psychiatrists, infectious disease, and so forth. And there's definitely now a push to be able to really recognize and operationalize recommendations that have been put forth, but not just by ACGME and JCO, but really even from a federal level. It is also quite staggering that back in 2011, Oberdeen and Maliver actually studied US medical schools and Canadian medical schools. And what we found was that only about 5 hours is devoted to LGBTQ health in the medical curriculum. And I, for one, certainly did not have much experience with being trained, and a lot of my training is really self-taught. And then moreover, during residency and even in fellowship, I did not necessarily get as much training as well. So there's definitely a need. And even though this is 1 hour of educational session, I hope that in my small way, I'm able to add to the number of hours that we have. Thankfully, in our medical school, through the work of Rina Karani, Rainer Suriano, Joe Trulio, David Muller, we have a more robust curriculum around LGBTQ health medicine. Now, let me just segue over to some nuggets about the palliative care piece. I was fortunate to be involved in this very esteemed group of researchers looking at the experiences of LGBT patients and families from a hospice and palliative care perspective. And we were able to publish this with the Journal of Palliative Medicine last year. This was a cross-sectional study that utilized an online survey as the method of collecting information. And what we really wanted to do was the perceptions of hospice and palliative care providers as far as discrimination is concerned, targeting patients in the LGBTQ population. Now, we were able to sample about 865 hospice and palliative care providers with a minimum of 18 years of clinical care service and a minimum of 9 years of hospice and palliative care service. And the results are staggering, though not surprising. 64% reported that transgender patients were more likely to be discriminated against for obvious reasons. And about 21% reported actual observation of discrimination towards transgender patients. 14% observed that SGM partners were disrespected. And overall, more than half of the respondents thought that LGBT patients were more likely to be discriminated against. So one of the limitations is obviously recall bias, because this was an online survey from a really a national scale. And I'm pretty sure the data here is underreported. And also the inclusion of the sample, there's also selection bias, because chances are that a lot of these individuals either are much more knowledgeable about LGBTQ at large or identify within the cohort as well. Let's look at some of the really painful behaviors that were described towards this population. There were many jokes that were made about how to address transgender patients. There was a lot of giggling about using the current name or pronoun. During a code situation, staff members were making jokes about what the pronouns to use for the patient. And one can only imagine how this is already an emotionally fraught and challenging situation. And then you are making fun of a patient who has died or at the brink of dying. A transgender woman in the ICU was critically ill and dying, and the primary bedside nurse refused to use her pronouns. The case manager had a patient whose partner was transgender and referred to the partner as it, and furthermore, propagating this notion of invisibility. And during their team rounds, the nurse later kept using the term he, she in reference to the patient's partner. There's also a account of a transport driver calling the patient it. LGBTQ patients as a whole were made fun of. And again, this is not uncommon because of the expression that people present externally. There was a transgender man under hospice care who developed urinary retention, and the nurse had inserted a catheter and had announced to some members, you've got to see what it looks like, because perhaps this man underwent gender realignment surgery. And then there was also a provider who noticed that one of their fellows asked a patient, so what are you, a boy or girl? And then estranged family members were given more of the onus to visit and also to make medical decisions, as opposed to chosen families who have been in much more in communication with their patients. So the takeaway from these vignettes is that there have been numerous accounts of disrespectful and discriminatory behaviors towards transgender patients at large, but really LGBTQ patients as a whole. So I'd like to segue over to a more hopeful note, that in spite of the fact of the longstanding oppression and stigma and discrimination of the LGBTQ population, when it comes to end-of-life care preparations, this study by Chris Comte in the Journal of Social Work and End-of-Life Palliative Care actually highlighted that our LGBTQ patients are much more savvy and much more prepared in terms of end-of-life preparations. Overwhelming majority had discussed end-of-life care preferences with primary care providers. They've also completed their own living wills, and they've also appointed a healthcare proxy. Now, this is in contradistinction to an older study back in 2001 by Stein and Bonock, when they looked at the perspectives of the LGBT population as far as end-of-life care. And what they found in the 2001 study was that even though LGBTQ population would rather receive palliative care and even physician aid in dying when they have a serious illness, what is striking at that time, and in contrast to now, was that even though more than 90% of the LGBTQ population were of the mindset that they can in fact prepare for end of life, only about a third of them actually completed their living will, advanced care, and other advanced care directives such as healthcare proxy, and had communicated their wishes to their healthcare providers. So along the vein of optimism and hope, I think that we've certainly seen some changes as far from a federal standpoint and from a governmental standpoint. I think that even though in the previous administration took away the SOGI information in the national surveys, thankfully the sexual orientation question was put back in the national survey for the Older Americans project. And why is this important for our geriatric population? The Older Americans Act ensures that our older adults get some access and resources to transportation, to meals, and also to home care services. So you can just imagine that if SOGI information is not collected, then the LGBTQ population will never receive the appropriate services that they need because they would have stayed hidden. Moreover, because the needs are very nuanced and very unique, then people are not going to be able to understand fully what the needs are. And again, there will be this complacency and perpetuation of invisibility. In 2019, the LGBT Data Inclusion Act, which was put forward by Rhode Island Senator David Cicilline, wanted to mandate federal agencies to really collect SOGI information, and not only collect SOGI information, but also to allocate resources based on their SOGI. In April, when the current president made his first address to the joint session of Congress and Senate, the current president actually really reassured the transgender Americans that he has the back of the transgender and gender non-binary population. And in February of this year, the House was able to pass the LGBTQ rights bill, which, if passed by the Senate and then signed by the president, can definitely make a significant change in various arenas that affect the LGBTQ plus population, from public accommodations to housing, to education, to employment, to other safe spaces. We're obviously very proud of Dr. Rachel Levine because she is the first woman of transgender experience to be the assistant to Secretary to Health, to Vivek Murthy. And she is also a graduate of Mount Sinai in the pediatrics program. As far as other legislation, I think that within our long-term care facilities, the Federal Nursing Home Reform Act of 1987 is definitely helpful because it really highlights the need to increase knowledge gaps and to impact a cultural shift by changing negative attitudes. And it also enforces that nursing homes and other long-term care institutions expand their research on LGBT elders, as well as really focusing on stronger collaboration with other institutions for systemic and structural changes. In this Reform Act, it also highlights the Residents' Bill of Rights, so much so that if an LGBTQ plus identified patient enters a long-term care facility, then they are protected by the Residents' Bill of Rights, and nobody can curtail their ability to be visited by their chosen families and or make decisions around their healthcare, appointing these individuals. We are also aware that in New York State, we actually have what we call the LGBTQ Healthcare Bill of Rights. And when you come into the main lobby of Mount Sinai, just before you get up the steps, on the very left side of the wall is the LGBTQ Bill of Rights, Healthcare Bill of Rights, that is plastered for everyone to see and to highlight that this is an inclusive and diverse and welcoming institution. And I think that also New York as a state has had the pioneering ability to not only cater to the LGBTQ population, but also really be inclusive and in creating safe spaces for this population. So they now have affordable housing called the Stonewall House in Brooklyn, which is a 17-story building with 145 units. Though this building primarily caters to the LGBTQ plus population, it is not by no means exclusive to them. Cisgender heterosexual individuals can be included as well. And unfortunately, it's all booked up and there's no availability. The one that's still open and actually not currently accepting applications is the Crotona Senior Residences up in the Bronx. This is affordable housing as well. And again, similar to the concept with Stonewall House, they're also very LGBT inclusive. And I think that the amazing thing about this housing is that especially for our older adults who have been victimized so many years and would like to reside in a facility or an area that their needs are well attended to and they don't have to pretend or they don't have to hide their own truth, these are actually great resources and great options. We actually dub them as aging in place. We do know that long-term care services are not solely nursing homes. They can also include adult daycare centers, assisted living facilities, etc. So let's go now to discuss, to talk about the first main objective, and this is describing the key concepts and constructs and hopefully some guiding principles in how we understand the LGBTQ population. So there are 7 constructs that I wanted to impart in this talk. There are definitely much more. However, we will run out of time. So I will just focus on the ones that I feel would be really helpful for everyone to understand. So the first one is sexual orientation and gender identity, known as SOGI. I always like to start with the gender unicorn and the SOGI Venn diagram, because this really highlights the interrelationship, the interdependence, and the overlap of all of these 3 concepts. Gender identity refers to a person's internal sense of who they are, whether they are male or female, masculine or feminine, somewhere in between, or none at all. Gender expression is the outward or physical expression of one's self through body language, through hairstyle, through fashion. Sex assigned at birth is really an important concept to be able to be inclusive of the gender and gender non-conforming population, because only then can we really truly identify, apart from them just openly disclosing who they are from the outset. Sexual orientation, on the other hand, is a different construct, and it's not to be misconstrued with gender identity. Sexual orientation is your physical and or your emotional and sexual attraction to a set of gender or genders. And there's now a term called cisgender, which is really the opposite of transgender. Transgender essentially means a mismatch of one's anatomy versus with one's gender identity. On the other hand, cisgender are individuals who biologically have parts and identify with the parts that they are born with. So there's a matching or alignment of their gender and gender identity and their anatomy. So in 2017, the New York Times published this article called "Gay and Transgender Patients to Doctors Will Tell, Just Ask." And this was lifted out of the equality study in 2017, looking at SOGI information. This was an exploratory sequential mixed method design in the Baltimore and greater Baltimore, DC area, looking at ED providers and LGBT and really patients from all walks of life. And what they wanted to find out was whether or not SOGI is something that will be readily disclosed and how important this is. And what you can see on the right side is that patients are less likely to refuse their SOGI if they were asked. And what's even more staggering in this data set is that only 10% of patients had actually refused delivering or disclosing their SOGI information to their healthcare providers. However, the disconnect was that about 2/3 of medical providers thought that patient would refuse SOGI information, whether or not that's just from a first impression or the provider's own discomfort of asking SOGI, or whether or not the provider did not necessarily think that SOGI was relevant to the care at hand. Only, again, the verdict is still out there. And I think what the bottom line here from this study is that if we implement a standardized patient-centered approach in SOGI data collection, then it's not going to be a big production and not a big to-do. And then in a correlative and parallel study, they asked the transgender patients, and the data was again about the same. 89% of transgender and gender non-binary patients felt that when asked, they would be okay to disclose their SOGI. But, close to 90% felt that gender identity was definitely important to disclose to their healthcare providers, because once you know the gender identity, a cultural and clinically competent provider can then move forward with affirmative and inclusive care in that regard. So the bottom line here is that even amongst transgender and gender non-binary patients, SOGI information can be readily disclosed if asked by the individuals. So some inclusive and affirmative practice tip is really including it in your electronic health records. So this is one example. You just lump it with all the demographics and not have, make a big deal out of it. Furthermore, when you have questions around gender identity and sex assigned at birth, you can clearly be inclusive for our transgender and gender non-binary patients, and you can definitely include their pronouns as well as part of affirmative action. In our EPIC electronic health record, You can actually find that through the work of Barbara Warren, Edgar Vargas, and the Office of Diversity and Inclusion at Sinai, they were able to champion the inclusion of SOGI and create a smart form. So on the left-hand side of your EPIC charts for your patients, where the pronouns are at, just underneath the name, you can click on the link and this will pop up, and you can then click on how your patients identify. And also of recent for this year, because there is now a push for SOGI to be really at the forefront, we wanted to really advocate that the Palliative Care Quality Collaborative, which is comprised of 6 national organizations, be intentional about including SOGI in its data set as far as research and programmatic involvements are concerned. The second construct that I wanted to touch on is that of the minority stress model, which was illustrated by Ilan Meyer, a social scientist, back in 2003. Essentially, what this model posits is that individuals, by and large, have general stressors, whether or not you're cisgender or transgender or LGBT or non-LGBT, you are faced with general stressors in daily life, from employment to housing to finances and so forth. And then if you belong to a minority population, like the LGBTQ plus population, you have your own unique stressors and your own unique life events, life experiences that can certainly add up to the general stressors that you already have. And what happens is that this will then result, the additive effects of the general and the minority stressors will then result in outward physical and mental health outcomes that could be adverse. Having said that, I think what Dr. Mayer also put here is the fact that in spite of the stressors, that the LGBTQ population actually have developed proper coping and social supports and have become really resilient over time by virtue of their life experiences. To fully understand this, we have to go back to the historical milestones. Back in the 1950s, being gay was considered a sociopathic personality disturbance and individuals were labeled as perverts. Thankfully, in 1969, through an uprising in the Stonewall Bar, the LGBTQ movement, the modern LGBTQ movement was born, really impacting the way that we look at protections and legislation and healthcare as a whole. Thankfully, in 1973, a gay psychiatrist by the name of John Fryer really advocated that homosexuality should be removed as a mental illness, and also, and also debunk this myth that transgender patients are, pathologic in nature. And so we can therefore see that over the next, 10 to 15, 20 years, we've definitely seen strides in the progress towards LGBTQ rights, from the repeal of Don't Ask, Don't Tell, the striking down of the Defense of Marriage Act, and in 2015, the federal recognition of same-sex marriages and relationships. So what happens when we care for our LGBTQ patients, and knowing the information that we now know about multiple stressors, knowingly or unknowingly, we can develop bias. And I think we have to just be bold to say that all of us have some form of unconscious bias. And it did not even necessarily apply to just the LGBTQ identifier. It could just be, from a racial standpoint, from a class standpoint, even from an educational standpoint. I think that we are all biased in some way. And the important thing is really to recognize that unconscious biases can result in negative evaluations and preconceived judgments towards our patients. And so therefore, one way to mitigate this is to engage in unconscious bias training. Thankfully, the Office for Diversity and Inclusion offer unconscious bias training here as well. So I will get more personal a little bit in the next couple of slides, because I think that this is really important. The concept of intersectionality is a very popular concept, especially in the last 5 years or so. This actually just pertains to the confluence of multiple factors that can impact the unique experience of the LGBTQ plus population. Essentially, these are domains that affect and define the individual. And these domains are not necessarily exclusive, but rather more interdependent. One domain probably more paramount or are more prominent than the other and more impactful. And the issue with intersectionality is that you can have layers of stigma around this by virtue of your race, your class, your ability, your gender identity, your ethnicity, and so forth. And then this becomes really important. So I'm going to use myself as a case study. This is me now, and 40 years later, I'm 80 years old, as a woman who identifies as heterosexual and also transgender, an immigrant, a foreign medical graduate, Asian, and a Filipino. In all of that, I am certainly aware and acutely aware of my surroundings and the challenges that I have faced to be able to live authentically as myself and to be able to care for the patients in a way that allows me to become empathic and really compassionate. But my journey, which is a different talk altogether, I just wanted to highlight that in spite of the challenges, that there are also resiliencies that I also wanted to uphold. Being in a department in geriatrics and palliative care who have been incredibly supportive from day one, and the support that I derive from my own family and friends, and in being just my own mindset, I am aware that as I age and as I become older, I would like to be able to receive the care that I so deserve, along with other brothers and sisters in the community as well, because we have all faced in one way, shape, or form significant oppression and stigmatization. And so I think what is important in my life story is our lived experiences, and this is not just for me, but really the community as well, that there are the lived experiences, and listening to the story is really paramount. We can think of it in two forms: life course theory and the goal-oriented theory. Life course means that in our trajectory, we have transitional points that were impactful, and goal-oriented theory is that as we evolve over time, our experiences that were shaped by challenges and triumphs will allow us to strive for better and whatever goals we have in order to stay afloat and to sustain life and also live healthily and age gracefully. So I think one of the affirmative tips here is to really listen to the stories of your patients. Speaking of resilience and robustness, the difference between the two is that resilience is the ability to withstand, stressors through successful adaptation and coping. On the other hand, robustness is the resistance of the individual to not even be affected at all by the stressors. And I think through individual versus community-based resilience supports like spirituality, advocacies, activism, we have then developed, the population has then developed what we call crisis competence. And so therefore, the tribulations and the adversities that have come before and have affected the LGBTQ population has also allowed them to survive and successfully within society and within the healthcare system at large. Finally, I can sum everything up through the principle of cultural humility. And I think that is one of the first steps. And you are all here listening to my talk when you could have listened to other talks or have done your own other responsibilities, but you chose to stay for an hour to hear what I have to say. And I think that that's already a testament to the cultural humility that you all embody. And I think that cultural humility and applying the principles of openness, self-reflection, self-awareness, a lifelong commitment, and this becomes a lifelong commitment to such, is incredibly important and powerful, and can really allow for the doors to be open so that you will have a relationship with your patients that are going to be strong, personalized, and also compassionate. So let us move forward with the second and the last objective. How do we then execute and operationalize all of these concepts? And I really wanted to be intentional and mindful of some of the communication nuances and clinical care strategies for this population. I'm pretty sure all of you, whether you know of somebody who's LGBTQ, you have already patients who are LGBTQ, you're probably already have a high level of competency. However, I hope that through the next few slides, you will continue to value and perhaps assimilate some of the tidbits that I wanted to share. So I think it starts out by creating an environment and an atmosphere of welcome and inclusivity. And I think that it starts with cultural and clinical competency training, and also having outward external symbols can be really powerful. So you can see in this slide, the different symbols that we use, from the rainbow flag to pins using your pronouns, or pins that highlight that you are a provider who is non-discriminatory and who is inclusive, and also even having non-discrimination signs on the wall in your offices will be really helpful to cultivate an atmosphere of welcome and inclusion. Moreover, I think that we need to really understand the rich history of the LGBTQ population by listening and demystifying some of those misconceptions and negative attitudes. We need to normalize the collection of SOGI, as was evidenced in previous slides. And there's also a really helpful tip, and this is, you can actually use this question. We use this a lot in palliative care. This is the Harvey Max Chochinov dignity question. What do I need to know about you as a person to give you the best care possible? If you use this as your opening question with an individual who you may or may not know is LGBT identified, it can really offer a lot of support to the individual that you are open-minded, that you are allowing a safe space for them to share their truth. And moreover, just because we're sitting and having this discussion doesn't really make us all experts. Even I will continue to learn. I think that, offline, we can still certainly do more by engaging in, free online training, such as the Safe Zone Project or even the SAGE Ambassador training. I think within our population, it doesn't have to be geriatric or palliative care. We just need to be mindful that advanced care planning is something that we should do from the get-go, from the moment a patient is being seen in the outpatient clinic, and start a relationship. I think this is really incredibly helpful for all of us. And I think that it definitely takes a village as well to help and support the LGBTQ population. And so you don't have to go through this alone. You can tap on other human resources like our social workers, our chaplains, psychologists, other therapists, pharmacists, and so forth, who can be really helpful in offering that support. I think that having support groups and open spaces for LGBT employees is really helpful as well, because it can trickle down to how we provide healthcare to our LGBTQ identified patients. And, definitely we need to standardize and expand our research, as well as our policies and non-discriminating regulations within our care settings, whether it's in the outpatient or inpatient or long-term care settings. So I'd like to end with just going through a few slides on some tangible communication strategies that might be helpful for all of us. And I'd like to start with a case vignette. So you are the clinician taking care of a 77-year-old person with a medical history pertinent for osteoarthritis, hypertension, type 2 diabetes, and insulin, and coronary artery disease, who was transferred from a nursing facility after a fall, resulting in a left femoral fracture and requiring surgery. You just attended a session on cultural and clinical competency and humility training on inclusive and affirmative care for everyone, including the LGBTQ population. How do we then go about doing your history taking and physical exam? So let's think of a few scenarios here. So let's say you start meeting the patient and you greet the patient. You can Be inclusive and affirmative by starting with your own introduction. So for instance, for me, hello, my name is Dr. Javier. My pronouns are she, her, hers. What is your name and what are your pronouns? How would you like to be called or addressed, right? So again, just normalizing the conversation. Maybe some of you might say, well, it's not really common for us to introduce ourselves with our pronouns. And what I will say is that perhaps we now need to do that because it is a way to be really inclusive and affirmative for our patients. If you are not comfortable doing that, then what you can do, there are other creative ways. You can carry a pin that says your pronouns, and this is very common. You can attach it to your name tag. So there are ways to openly disclose your pronouns and be comfortable with them. So the other thing is that when you're collecting information about your patient, I truly believe in proper scripting. Albeit ad-libbing is certainly, appropriate as well. So one narrative could be something along the lines of part of providing holistic and affirmative care to all patients is asking more specific and personal questions so that we can address each patient's unique needs. You can always opt out if you feel uncomfortable or if this gets too personal. So you can start with a disclaimer or a prefacing statement like that. And in a way, it's almost like, priming your patients and, for what's about to be shared or discussed within the encounter. You can also invoke the dignity question. What do I need to know about you as a person to provide you with the best care possible? Also, part of normalization is just asking outright, what is your sexual orientation and gender identity? Provided that this has not already been addressed in your electronic health record at with your front desk, and you are in the process of just getting acquainted with your patient. Another area is collecting psychosocial history. And I think this is really important because you can tap into questions around their support system, who are the important people in their lives, their relationship status, their current living situation, and so forth. And you can also include here, the advanced care planning piece as we, check those box out. So again, the care for our geriatric and palliative care patients are not necessarily completely different. It's nuanced, but it is not completely different from the way that we obtain psychosocial history with our cisgender heterosexual patients. Doing a physical exam is a little tricky, especially for our transgender and gender non-binary patients. I think you need to start out by asking permission. Things like statements like, is this okay? Can I proceed with a physical exam? How would you like me to proceed with a physical exam? If at any point you are uncomfortable, please let me know and we can defer the exam. I'll do it later. For transgender and non-binary or non-conforming patients, how would you like me to refer to your body parts? And in this way, you can do a proper anatomic inventory while continuing to examine the patient and also explain to them why you're doing this examination on their private parts or why you're doing like a thorough examination, including their private parts. The other thing that sometimes is overlooked is sexual health. Even in our geriatric and palliative care patients, sexual health is something that is really, really important to talk about. And I think that if we don't ask the question, it's almost like a don't ask, don't tell. If you don't ask, people will not tell. So I think that we need to, ask universally sexual health with our patients. And I think that we've also come a long way so far. I remember back in the day when I was in training, this was really not something that I was used to asking. And now it's kind of, a reflex that I really tap into the sexual health piece. And again, it's asking permission, putting priming statements like, I want to be respectful of your comfort level. Is it okay to ask questions? And you can go much more in depth regarding some of the sexual practices. So one of the common scenarios is misgendering a transgender and non-binary or non-conforming patient. So when that happens, and you call them by the wrong pronouns or the wrong names, and the reason and how this might happen is that, for instance, if a TGNC or TGNB patient has not had their official IDs changed, their proper names and pronouns, the discordance can also cause a discordance within the providers and can be quite confusing. So if you commit a mistake, you apologize, you immediately call the patient by the right name and pronouns, you move on to the next part of your history taking, and be intentional about moving forward without, with avoiding committing the same mistake. A lot of the times transgender and gender non-binary patients are quite forgiving with mistakes, but if the individual continues to perpetuate the behavior, then that's a different story. And as far as goals of care discussion, which we all include in our day-to-day practice as a geriatrician, as a palliative care clinician, I am also aware that, again, we don't have to reinvent the wheel, and communication tools like the spikes, nurse statements, and remap are important tools that we use in delivering serious news, navigating emotions, and also reframing goals. I think that, again, even during the goals of care discussion, just asking a very open-ended question like the dignity question is quite helpful. What is also helpful now that the previous concepts that was explained to you is that when we look at the patient who identifies as LGBTQ, there is now an intentional contextualization of the goals of care discussion, because we have to consider and we have to factor in the lived experiences, the minority stressors, the stigmas, the coping and resilient mechanisms that these patients have. And in that way, the discussion doesn't occur in a vacuum, and that it actually is very meaningful because you're recognizing all of these facets of the human being in front of you. I think it's really important to include chosen families as well, and any other support network. Some have really good relations with their biological or vertical families, so definitely include them. And I could not overemphasize that an interprofessional approach is paramount and integral to providing holistic care. A chaplain can certainly explore a little bit about the spiritual side of things using the FICA tool. Our social workers can explore, supports, assistance with daily livings, and other transitions in care. So in summary, I wanted to just share with you 4 important points that you can take away from this session. The first one is really highlighting that the older adult LGBTQ population and the individuals with serious illness are marginalized community with unique healthcare needs, and are affected by numerous disparities in the provision of high quality medical care, including geriatric, palliative, hospice, and end-of-life care. I think that we need to engage in cultural and clinical competency, which are 2 different constructs. The clinical piece is the knowledge base, and the cultural piece is really understanding their culture. Through cultural humility training and have an understanding of minority stressors, SOGI collection is really important, being aware about our implicit biases, and also looking at a framework of intersectionality and resiliency in terms of how we take care of our older adults and patients with serious illness. I think that we also need to be intentional about engaging in a cultural shift in attitudes, beliefs, and practices. And it starts out by just having a discussion, and it starts out by applying some of the things you have learned today in your day-to-day practice and not be apologetic for it. Being able to normalize the care and the conversation, and that should not really be a big deal. And finally, I think that there continues to be gaps in research and federal and state policies. I'm really hoping and praying that the Equality Act will be passed sooner rather than later. And that thankfully, since 2011, we have a burgeoning surge of research in the areas of LGBTQ, especially around older adults and palliative care. That said, in comparison to let's say our cardiology colleagues, that the research is still will still need a lot of work. These are just some selected readings and resources that you guys can go to and access them, because I think that they're really powerful and helpful, and the slides can be available for you to rewatch again. I'd like to end with a quotable quote from one of my famous champions and one of my favorite authors, James Baldwin, who is an LGBTQ advocate. So what he said was that not everything that is faced can be changed, but nothing can be changed until it is faced. So I end with that. We have about a minute. Thank you so much for allowing me to present and for listening to my session and also to my story. Thanks so much.
Thank you very much, Dr. Javier. It was great, very comprehensive. We are at the end of time, but there is a question in the chat. I think that's there. We can address if you like.
So it says here, passing a law does not change what people believe or do. Have investigations or polling been done to show whether red or blue states have changed their beliefs or actions in relation to LGBTQ people over the past few years, changed after new laws made a difference from before, after such laws passed or failed? Ignore the question if this answers, since I must leave early. Oh, okay. So there has been, so I completely agree with Michael Greenberg's comment here that passing a law is a step, but it is not a be all and end all of creating change. There have been some polls around, blue states, primarily blue states, because a lot of the red states may not necessarily, again, it's not that they don't want to address the issue, but it's not necessarily considered a priority. So a lot of the data that we have is really more around the blue states and how this has changed, over time. So unfortunately, there's still a paucity in this area. And I think that this is an area that we can continue to advocate for and really champion.
So we do have one, and why don't we end on a very positive note, Noelle Marie. So we have here more people saying thank you, but just got one. Thank you so much, Noelle Marie, for sharing your wisdom and story with us this morning. It's really appreciated. Happy holidays.
Thank you so much.
Maybe with that, I extend a big thank you to you, Noelle, and happy holidays to everybody, and see you all in the new year.